تمام. Dear all, it's my pleasure to start the session of tachycardia. It's a part of the mentorship program 20 and 24. It's my pleasure to have Dr. Osama from Yemen, Dr. Amna from Tunis, and Dr. Azza from Egypt. At first, I'd like to invite them to introduce themselves. Dr. Azza, please introduce yourself to our colleagues.
I'm a cardiology consultant and electrophysiology consultant at National Heart Institute. It's a tertiary center in Egypt, receiving patients from all over Egypt. Okay.
You are welcome, Dr. Azza. Dr. Amna.
Hi, everybody. I'm very glad to be a part of this program. I'm Dr. Amna Alouche. I'm associate professor in the medicine school of Tunis. I'm a cardiologist and EP consultant in Charles Hospital in Tunis.
Welcome, Dr. Amna. Dr. Osama.
Thank you very much. I'm glad to share you this session. Dr. Osama Nuno, Assistant Professor of Cardiology, EP Consultant, University of Sana'a.
And me, Mohammed Abdul Basit, Lecturer of Cardiology at the University. It's my pleasure to share this session as interactive session to educate our colleagues how to approach a case of tachycardia and how to deal with such an important presentation in the emergency room and how to refer for further management. So these are our topics today. We will talk about regular narrow-complex tachycardia, regular wide complex tachycardia, and accessory pathway-based tachyarrhythmias in irregular arrhythmia. Starting with regular narrow-complex tachycardia, and my question to you, Dr. Osama, how you define narrow-complex tachycardia?
We have a QRS complex of 120 milliseconds and a heart rate of 100 beats per minute to diagnose a QRS complex tachycardia of narrow complex.
So there is supraventricular and ventricular tachycardia. Is EV node supraventricular or ventricular structure?
Actually, it is supraventricular. It's better to approach the tachycardia as narrow and wide complex tachycardia here. Just behind this blue line, any tachycardia can present with narrow complex QRS complex, and including all origins from the pulmonary veins, from the left atrium, right atrium, and also including the orthodromic AV reentrant tachycardia that is descend through the conductive system and return back through the accessory pathway will present with a narrow complex tachycardia.
So my question to you, Professor, as one of the expert EBS in Egypt, when supraventricular tachycardia become wide and when ventricular tachycardia become narrow complex?
If we have a functional or anatomical bundle branch block across below his Purkinje system, either on the left side, the left bundle branch block, or the right bundle branch block. If we have anatomical, meaning that there is a pre-existing bundle branch block with the patient, and so the tachycardia will come with a wide complex. And so we have always to compare the sinus rhythm of the patient and the tachycardia complex to see if they have the same bundle branch block or to show that there is a pre-existing bundle branch block and the same axis. Okay,
yes.
Or it might be functional due to the high rate of the tachycardia. There will be we will reach the refractory period of one of the bundles, and so it will go with the bundle branch block. Okay, this is concerning supraventricular tachycardia when it comes wide. The other way around, we have to suspect always when the tachycardia is just 120 milliseconds. Are we from the atria or the AV node, as Dr. Osama said? What is the origin of the tachycardia, or if it is coming from the below the Purkinje system, it will give exactly 120 milliseconds, and this will be discussed, I think, with the wide complex tachycardia.
Yes, very important point. So if we have simultaneous ventricular activation at the same time, so we'll get narrow complex rhythm. If we had one ventricle to be activated before the other, cause of any of the causes you mentioned, so we'll have wide complex tachycardia. So back to Dr. Osama, what is your differential diagnosis of narrow complex tachycardia?
Okay, the common narrow complex tachycardias are sinus tachycardia, appropriate and inappropriate, and atrial tachycardia, atrial fibrillation, flutter, AV nodal reentrant tachycardia, and AV reentrant tachycardia, as well as the fast fascicular tachycardia can present with narrow complex.
Dr. Amna, could you simplify the EVNRT? What is EVNRT and EVRT, especially our trainee maybe juniors in the cardiology. What is the meaning of EVNRT and EVRT?
EVNRT, that's when the node, atrioventricular node is a part of the tachycardia circuit. EVRT, that's the tachycardia. There are bypass between the atria and the ventricles, and we will discuss this in pre-excitation syndromes.
So EVNRT is the entry inside the AV node between the slow and fast pathway, but EVRT is the entry between the atrial and ventricle utilizing an accessory pathway. So what is your role, Dr. Osama, in diagnosing narrow-complex tachycardia?
First of all, we have to check the regularity. Is it regular arrhythmia or an irregular arrhythmia? So, and then we will check for the presence of P waves and their relation to the QRS complexes. And if there is an irregular rhythm, we are dealing of either a free AV atrial fibrillation, atrial flutter, or multifocal atrial tachycardia. If the tachycardia is regular with a P wave that cannot be visible, so we are dealing with a typical AV nodal reentrant tachycardia. If the P wave is visible, but the atrial rate is more than ventricular, it is either of two atrial flutter or atrial tachycardia with fixed conduction. If the P waves are R waves are equal, so we should look for the RP interval. If it is a short RP interval less than 70 milliseconds, again we are dealing with AV nodal reentrant tachycardia. If it is long RP interval more than 70 milliseconds, most probably even AV reentrant tachycardia or Parkinson-White. This is a simplified approach of regular and irregular narrow-complex tachycardia. The most common arrhythmia, regular narrow-complex tachycardia are atrial tachycardia, AV nodal, AV reentrant, and the most common of them worldwide is the AV nodal tachycardia, 60%, and 30% AV reentrant, and the atrial tachycardia. And it is noted that with the age, the AV nodal and the atrial tachycardia will increase in size or in frequency, and the more Parkinson-White arrhythmias are less and less with the age. This is the plotting. If you can see the just okay. Here is the
yes,
the internodal pathways. We have
Dr.
the fast
Osama
pathway,
to explain to our colleagues
with their
concepts.
Okay, we have the internodal pathways. We have a slow pathway and the fast pathway. The slow pathway usually have a short refractory period, and the fast pathway a long refractory period. And during standard rhythm, usually the impulse will propagate through the fast pathway and return back through the slow pathway, and the two impulses will fuse, and just one single beat go back to the ventricle, and so the arrhythmia will not happen. So during standard rhythm, no reentry can happen unless there is an extra systole that will come and reaching the one of the pathways is refractory, usually the fast pathway, which has, yes, this is the impulse that is coming in as an extra systoles, and will reach the fast pathway, which is in refractory period, so this impulse will vanish. But in the other way, it will go through the slow pathway, reaching the Hess bundle, and unfortunately, it can go also after even going through to the ventricles, and also through the fast pathway to the atrium, and so the arrhythmia happens. So there is reentry, it goes through the slow pathway and then return back through the fast pathway. So this is the most common AV nodal reentrant tachycardia, slow fast reentrant tachycardia.
My question to you, Dr. Azza, where in the heart could reentry occur? Is most common forms of reentry we could face in the heart?
You mean, I haven't really got your question, but if you mean if it's on a normal heart or a diseased heart, or we have first when we have it when we evaluate a patient with tachycardia, we have after evaluation of the tachycardia, if it's narrow or wide, and if the patient is hemodynamically stable or not, but we have to know if this tachycardia comes on a normal heart or a structurally diseased heart. Okay, most commonly these narrow complex tachycardias like the EVNRT comes on a normal heart. There's no structural heart disease. But sometimes we can find if there's, a fibrosed area either in the atria or in the ventricle. This will get a substrate for the re-entry. We will get the basis of the re-entry with the two limbs or of different refractory periods and different conduction velocities, like a person like in congenital heart disease, for instance. We can have patients with atriotomy. I think this will come later on in our discussion. Patients with atriotomy, this will create an area of re-entry around the skull. This is what is known as anatomical substrate for the arrhythmia, for the supraventricular arrhythmias.
So re-entry could occur in structurally normal heart and could occur in patient with underlying structural heart disease, either congenital, ischemic, fibrosis, and so on. So my question to you, Dr. Osama, how you could approach such narrow complex tachycardia in this ECG?
Okay, in this ECG, we have a narrow complex tachycardia. The P wave is not that positive, visible. We have the P wave and the Cardiac complex are coincidental. So according to our simplified approach above, we have an AV nodal enteric tachycardia. If you can see the ECG below, which is the sinus rhythm, you can just compare. If you turn back, okay, you can just compare the Cardiac complex in V1 as identical. So the P wave is inside the Cardiac complex. So once the P wave is not visible and regular tachycardia, we are dealing with AV nodal enteric tachycardia. If the next is in this next ECG, we see that there is if you just click on for the sinus rhythm, okay, here you can just find that there is difference between the Cardiac complex in V1 and inferior leads, where we have what we call pseudo R prime in V1 and pseudo S in inferior leads. This is the retrograde P wave with an RP interval short, less than 70 milliseconds. So we are dealing with again AV nodal enteric tachycardia, as the atrium and ventricular activation are in the same time. In the next slide, we have also again clear R prime or pseudo R prime in V1 if we compare with the sinus rhythm. So it is again AV nodal enteric tachycardia, which is the most common tachycardia. This tachycardia usually finish with an atrium. Here we have a narrow complex tachycardia, which is regular, with a heart rate between 140 and 150. This should raise the suspicion always of atrial flutter with 2-to-1 conduction. Now, it is almost always the only arrhythmia that behave in this manner, in a 2-to-1 conduction. If we just magnify V1 and V2, we'll see that P waves here, 2 P waves and then Cardiac complex. It is positive in V1 and negative inferior leads. So we are dealing with common typical atrial flutter, response dependent, and a very common arrhythmia.
Actually, a very common ECG, but risky ECG, as atrial flutter carries the same thromboembolic risk of atrial fibrillation. If juniors deal with atrial flutter 2-to-1 as regular SVT, restoring sinus rhythm without looking for the onset of atrial flutter, so it increases the risk of stroke. Professor, did you face a patient with stroke before, after inappropriate management of atrial flutter?
Actually, yes. Recently, I have a patient, a Sudanese patient, who was referred for ablation because of tachy-induced cardiomyopathy, which is a common entity in tachyarrhythmias. And we should always, when we find the cardiomyopathy in a patient, we should search for if there is an arrhythmia or not, because correction of the arrhythmia might lead to correction of the cardiomyopathy. And this patient was referred for ablation, and then we did a transesophageal preparing the patient for cardioversion or for ablation. Unfortunately, there was a left atrial appendage thrombus, and so the patient was kept on anticoagulation. Unfortunately, during the time he's waiting for the next transesophageal after 3 months, the patient regained sinus rhythm on the antiarrhythmics, and this led to a huge stroke. Was an embolic stroke that left the patient handicapped. But during management, this was a terrible patient. Actually, it made me feel very sad for him.
Very, very horrible case.
Yes.
Dr. Amna, do you have plenty of cases of rheumatic heart disease, rheumatic mitral stenosis in Tunis?
We have, but not as important as in the past.
Yes,
in the transition.
So you have more patient with non-valvular AF. Here in Egypt, we have plenty cases of rheumatic heart disease. And in Yemen, Dr. Osama, do you have cases?
In Yemen as well, we have. Still, rheumatic heart is a very, very big problem, and very, very common disastrous disease. Rheumatic
Just
heart.
to comment.
Yes, Dr.
Please,
Amna.
may I comment the last ECG, please? The flutter one.
Again?
Yes, in those cases of patients with tachycardia around 150, if we are suspecting atrial flutter, I advise to juniors to try vagal maneuvers to try to slow the AV conduction, and we have to see clearly the F waves, the atrial flutter waves. If we slow ventricular rhythm.
So
It's,
slowing ventricular rate or ventricular AV nodal conduction could unmask the flutter waves hidden before
Yes.
each QRS. Vasovagal maneuvers has many uses. Anyone here get migraine headache? Vasovagal stimulation could abort the migraine attack, especially carotid massage. And I heard a lot from patients with migraine. They always say that the headache totally abort after vomiting. So I searched the literature. I found a device for carotid stimulation in patient with migraine. Just يعني big point كده with vasovagal maneuvers. So back to you, to Dr. Osama.
When they trying, excuse me, when trying to do carotid massage, we have to do one side by side, not the two at the same time, and they have to hear to
auscultate. Yes, you have to auscultate carotid for anything. Yes.
The high risk of stroke.
And we don't recommend vasovagal carotid massage in old patients. Carotid arteries always has plenty of plaques that are ready for getting stroke. So back to you, to Dr. Osama. How could you approach such ECG?
Okay, a third arrhythmia common is the focal atrial arrhythmia. Focal atrial tachycardia. We can see here that the P wave in inferior release is negative. So we're dealing with an arrhythmia that is coming from the base of the atrium, left or right. And this tachycardia usually finish with ventricle. You can see here that it finished with the ventricle and then the sinus thread return back. This is a monofocal atrial tachycardia, which is also common. So our tricks to treat these patients, the AV nodal tachycardia, usually vagal maneuvers, the adenosine, the verapamil, as they are coming from around the AV node, the conductive system, which is sensitive for adenosine and verapamil, because it is calcium dependent, has calcium dependent action potential. Whereas the atrial tachycardias are coming from myocardium, which is sodium dependent action potential. So they are more sensitive for calcium blockers, sodium blockers. Actually, the calcium blockers can slow the AV conduction, but many times will not block the tachycardia. While the atrial flutter and in general, the macrorenal tachycardias are less sensitive for drugs. They may slow the re-entry, and then they may return back the tachycardia more severe, as the flecainide, for example, can transform the 2-to-1 AV atrial flutter to 1-to-1 with a rate of 180, for example. So it will conduct 1-to-1 conduction, and the patient will become more symptomatic for this arrhythmia. So either to overdrive this arrhythmia or to DC shock the patient once it is we are sure that it is less than 24 hours and anticoagulated well, or the transesophageal echo was done, and so on. The chronic treatment or the curable treatment for these drugs is ablation, for these arrhythmias are ablation. The ablation of AV node is the posterior in the posterior triangle of Koch. Whereas the slow pathway is seated, so ablation is there. It will cure the patient. The atrial flutter, usually the isthmus, cavotricuspid isthmus ablation, and the atrial tachycardia according to the mapping. We will have also the orthodromic AV renal tachycardia that Prof. Abza will speak about.
So if we want Dr. Azza to order the ablation from safe to dangerous in narrow complex tachycardia, which is a piece of cake for juniors to start with, either NRT ablation or atrial flutter ablation. Open your mic, please. Open the mic, Dr. Azza, as we don't hear you.
Okay, I'm sorry. Before doing the ablation procedure, juniors should know the indications. They have to know that narrow-complex tachycardia, 90% of the narrow-complex tachycardia, or even more, according to the guidelines of the supraventricular tachycardia, the European 2019, shows that the success rate is very high with a minimal complication rate. And so they should offer the patient the process of ablation better than medical therapy. I'm not sure if Dr. Amna and Dr. Osama and Yemen refer the juniors refer always the patients or not, because here in Egypt they refer the patient mostly when they, general cardiologists and juniors, they refer the patient when medical therapy fails, not from the beginning.
Yes.
And so, number one, they have to know that mostly juniors should know that mostly narrow complex tachycardia is amenable for safe ablation with minimal rate of complications. Okay, this is number one. I can say that EVNRT could be a piece of cake or accessory pathways a piece of cake, but knowing in addition to the electrophysiology, people should know the anatomy perfectly well, so that to avoid complications. EVNRT could be a piece of cake, but sometimes it could be a piece of the hell. If it's very close in the triangle of Koch, you have to go very high near the AV node, or the patient can go into complete heart block. Okay, and so just knowing the anatomy perfectly well, knowing the triangle of Koch is variable between patients. Sometimes it is a narrow one. It's different between patients, and so just knowing the anatomy perfectly well will help young electrophysiologists and fellows that you can ablate safely and efficiently with the minimum rate of complications.
So my question to you, Dr. Amna, what are the dangerous signs during ablation of narrow-complex tachycardia that indicate that the patient could have complete heart block soon? Any signs during ablation could raise the suspicion that we are approaching AV node, approaching a dangerous area during ablation, like fast junctionals, slow junctionals?
I think fast junctional
is more dangerous.
rhythm is very dangerous, right?
So
And
if you have a fast junctional rhythm during ablation, you have to remove your foot from the switch.
And as said Dr. Azza, they should know very well the anatomy and the radioscopic anatomy, and we have to explore and to make sure that's reentry or nodal reentry or another accessory pathway, and to choose the best energy to ablate.
Yes. So we have finished the topic of narrow-complex tachycardia, and the key message to remember: just patient with unstable hemodynamics, hypotension, heart failure, or acute chest pain, you will be DC shock. If the patient is stable and has regular narrow-complex tachycardia, we'll start with vagal maneuvers. Then we'll go for the available drugs, either adenosine, verapamil. Actually, we don't have verapamil in Zagazig 1 month. Do you have verapamil in Cairo, Dr. Azza? I think is absent from market.
Verapamil, yes, is absent. Even
available
in Yemen. It's okay. So
verapamil, adenosine are available.
Okay, we could get.
You will send us.
You are rich man, Dr. Osama.
So the market is full of drugs. I would just emphasize that.
Adenosine is not expensive. Actually, it is not available.
I think that the pharmaceutical industry should use adenosine in our countries. It's not a very expensive medication.
Yes. So moving to wide complex tachycardia, which by logic definition is QRS equal or more than 120. Dr. Amna, what is the differential diagnosis of wide complex tachycardia?
Wide complex tachycardia is when the arrhythmia originates out of the normal conduction systems, especially VT, or when, as said Dr. Azza previously, when it's supraventricular tachycardia with conducted to the ventricle with aberrancy or with pre-existing bundle block, functional or pre-existent, or when there is pre-excited supraventricular tachycardia, or when if the patient is on a medication on an antiarrhythmic drug as amiodarone or class 1A or 1C antiarrhythmic drugs who widen the QRS and the intraventricular conduction, and more situation when the patient had hyperkalemia, especially patients with renal with kidney disease or under artificial kidney therapy.
So patient with acute renal impairment, sometimes it is deceiving patient in ZR present with acute dyspnea, just acute dyspnea, due to
very wide QRS
acidosis, wide complex rhythm, hyperkalemia. So without using the ABCD approach, many patients could be missed in ZR without performing random blood sugar ABG during the initial assessment. Such patient could be missed in ZR. So what is the Brugada algorithm for differentiating VT from SVT, Dr. Anna?
So to differentiate the ventricular tachycardia, which is the most severe diagnosis or most
more dangerous,
more dangerous diagnosis than the supraventricular tachycardia. We have many algorithms were developed to distinguish this two tachycardia in the emergency rooms. And the most famous is the Brugada algorithm, which is in 4 steps. First of all, we have to look the precordial leads, and there if we have or negative or positive concordance, this is that have a specificity at 100% of this that will be a VT. If not, we have to measure R to S interval, and when it's superior to 100 milliseconds in any precordial leads, it's predictive of VT with a specificity of 98%. If we don't find this, we move to searching for the atrioventricular dissociation. We have to look for the P waves between QRS complexes, and we have, if there is a dissociation with the QRS more than the P waves, this is also specific at 98% of VT. If we don't find this sign, we move to the morphology of the QRS in the precordial leads to see if it is typical or atypical morphology of right bundle branch or left bundle branch. And this slide is showing the morphology of right bundle branch criteria in VT, in V1, V6, or left bundle branch for VT.
So, Dr. Azza, my question to you, true or false? Ventricular tachycardia is acute coronary syndrome until proved otherwise. Your comment.
Excuse me, I haven't heard the question.
I want your comment, true or false? Ventricular tachycardia is acute coronary syndrome until proved otherwise. So we have to deal with all patients with ventricular tachycardia as acute or suspected acute coronary syndrome?
I do agree. Any patient above 40, what complex tachycardia should be considered VT until proved otherwise, and should be excluded as an ischemic patient, either in an acute ischemia or chronic ischemia. Although wide complex tachycardia, stable, monomorphic, always denotes the pre-existing of a substrate for in ischemic patients. I mean, a substrate for the VT. But also we have to exclude acute ischemia because this might be the solution for the problem. And so number 1 is coronary angio in patients to exclude ischemia and revascularization as early as possible.
So Dr. Amna, after finishing Brugada algorithm, could you simplify such a new algorithm for detection of VT versus supraventricular tachycardia?
So Dr. Verikay suggests this algorithm, and he starts by searching the AV dissociation. If for him, if this sign is present, this is a VT. This is a VT. Then he looks for the AVR lead, and if there are an initial R wave in this lead, this is a VT. Then he looks for the QRS morphology, and then if the morphology is not in favor of ventricular tachycardia,
so here this is the equation, the VI and VT, the initial and the terminal. Very complex to apply in ECG actually. But the question to the juniors about AV dissociation and the secret French key, I think it is French, yeah?
Yes.
How to reveal or unmask the P wave in ventricular tachycardia to detect AV dissociation?
There are many
ways.
First of all, we can amplify the recording of the ECG to search in between the QRS. Is there an accident who is coming regularly? Those are the P waves, or there are described in the literature 2 leads to record. The Lewis lead, when we put the lead of the right hand on the third intercostal space, and the lead of the left hand in the place of V1, and we have to look to the the first lead, the lead one, and we may see the dissociation, the AV dissociation. There is another lead we can record, the Leon lead, and we are putting the lead of the left leg on the xiphoid on epigastric, and the lead of the right hand on the second or the third intercostal space.
So utilizing limb leads to
record the activity in the atria.
Yes, this is example for what you want to say here.
Yes, this is wide complex tachycardia. The AV dissociation is not very we can't distinguish, but when we record the Leon lead, we can see these P waves on this dissociation in lead 2.
Yes. Perfect. And we use the vagal maneuvers for termination of supraventricular tachycardia. But again, vagal maneuvers, is there a rule for vagal maneuvers in patient with ventricular tachycardia?
When we have a patient with wide complex tachycardia and hemodynamically the patient is stable, we can try vagal maneuvers for diagnosis. If it's supraventricular tachycardia, it may be stopped.
Here in Sharqiyya, Dr. Azza, we always DC shock for any patient with ventricular tachycardia, unless the patient has a low risk profile and young age and highly suspected idiopathic VT. Do you prefer in elder patients with stable ventricular tachycardia to try any form of antiarrhythmic drug or DC shock as we do?
Actually, for elderly patients and even in younger patients, if people are suspicious about the tachycardia, please think as a VT until proved otherwise, because you can have VT in young patients, sometimes with normal heart. Even now, at the present time, we see a lot of myocarditis after the COVID area, and a lot of patients have underlying fibrosis in the myocardium. And so we have always to suspect the VT and not say that the patient is young, the patient is not ischemic, he has low profile for risk factors, and so this is mostly as VT with aberration. No, please think it as VT until proved otherwise. If anyone sitting in the ER suspecting when he does not know to differentiate the SVT from the VT, please treat it as VT, because if you give verapamil, which is the only available AV blocking agent in the ER in Egypt, if you give verapamil for VT, the patient will get the hemodynamic instability and he will have a hemodynamic collapse and he might arrest. But on the other hand, if it is if he treated the patient as VT, this is the safest. If he gave DC for a patient with SVT with aberration, it will not harm the patient by any means. And so this is very important. This is an important message to junior doctors. Please, if you don't know, treat it as VT until proved otherwise.
But my question, Dr. Azza, yes, we have to deal with all wide complex tachycardia in the ER as ventricular tachycardia until proved otherwise. My question, in patient with a stable suspected ventricular tachycardia, do you prefer to try amiodarone or for DC shock for all patients with VT?
No, I don't recommend the DC for all patients. We have to examine the patient. If there are no signs of hemodynamic instability, yes, we can proceed. And if we have the capability to ask electrophysiologists, people responsible for the arrhythmia, why not to ask what is this, so that people can upgrade. If we have deeper insight for the ECG, like we can differentiate the tachycardias like idiopathic RVOT VT. We can know the fascicular VT. It has a very characteristic ECG and it's very sensitive for verapamil. And so why not to ask? Just if not, if the patient is hemodynamically stable, we can proceed for amiodarone. Why not?
For how long should the junior wait for amiodarone to terminate ventricular tachycardia before DC shock?
I'm not sure about this for a time. But after the loading and the beginning of the maintenance, those patients should be referred to sinus rhythm.
If not, DC shock.
We shouldn't leave the patient in tachycardia for a long time.
Yes, and there is another trick for patient with recurrent VTs. If we could insert temporary pacemaker to overdrive pacing and termination. If the patient is in recurrent unstable ventricular tachycardia and recurrent DC shocks, we could use temporary pacemaker for overdrive pacing and termination for ventricular tachycardia. And there is some trick I said the last recording about the use of temporary pacemaker in differentiation. And if the patient is going to perform temporary pacemaker as he is in recurrent wide complex arrhythmia, I insert the temporary pacemaker first in the atrium to see the sensing rate from the atrium. If the sensing rate of the atrium is equal to the to the arrhythmia, so it is mostly antidromic AVRT or ventricular tachycardia with retrograde conduction. But if there is complete dissociation between the sensed atrial rate and the arrhythmia rate, so it is 100% ventricular tachycardia, just a diagnostic trick. But we don't need temporary pacemaker unless the patient has recurrent DC shocks and recurrent attacks of ventricular tachycardia.
For patients who have almost their ICD, we have to put amount on the ICD when there are recurrent VT or ventricular stroke to avoid multiple shocks.
But ICD and the ventricular storm actually is debatable point-wise to terminate the storm first or to insert the ICD first.
No, for patients who had their ICD on patients already with ICDs. For patients that have already their ICDs and they make recurrent ventricular tachycardia or ventricular storm. In emergency room, they have to get an amount to stop the ICD, to make management of the patient possible, because if the patient is receiving multiple shocks, nobody will treat him.
Will tolerate, yes. And the battery will be empty. So back to the management of wide complex tachycardia, we said if the patient is unstable, we will go for DC shock. If the patient is stable, the message Dr. Azza said that we have to deal with all patients as ventricular tachycardia until proof otherwise. If it is stable wide complex tachycardia, and we have to try, so we could safely try amiodarone. Even if it is supraventricular tachycardia, it could be safe. But if there is a stable patient and we have time, we could consult for opinion for electrophysiologist for accurate diagnosis of the type of ventricular tachycardia. So moving to the topic, which is important topic in the current guidelines, which is pre-excitation syndromes. Could you, Dr. Azza, introduce pre-excitation syndromes to junior cardiologists who start the career?
When approaching patients with tachycardia, whether narrow or wide, this will be we'll collect all the data we are discussing from the beginning of this discussion. Excitatory pathways is a common entity that the people juniors should think about. The only connection between the atria and the ventricle is the AV node. There shouldn't be any connection because there's the fibrous string between the two atria and the two ventricles. Only the AV node is the connection. If there is an extra connection between the atria and the ventricle, I mean extra single or multiple muscle strains that connects the atria and the ventricle along the AV annulus. This is known as a bypass track, and this bypass track does not follow the normal rules of the AV conduction. It will conduct very fast if it is working in the antigrade fashion, resulting in a short. I'm sorry, the previous slide. A short PR. Yes, a short PR interval. Normally, the PR is not less than 120 milliseconds. Having a short PR with a pre-excitation or delta wave at the beginning of the QRS complex with the characteristic repolarization abnormalities. Okay, and this pre-excitation or accessory pathways was discovered in or were first described in 1930 by the three scientists known Wolff and Parkinson and White, and that's why it's known as Wolff-Parkinson-White syndrome.
Yes. So how could we approach the ECG with pre-excitation, and your tips and the tricks for localizing the site of accessory pathway?
The point is that during sinus rhythm, the impulse comes from the SA node traveling to the ventricle. It has two pathways, the atria, the AV node, and the accessory pathway. And so the resultant QRS complex will be a fusion between both. Okay, the closer the accessory pathway to the AV node, it will be more or less narrower complex. But if it is far away from the AV node, it will be very wide complex. And so we will have a short PR interval that is around 120 milliseconds, and then followed by a delta wave. Followed by a delta wave. That's at the beginning of the QRS complex. If we need to localize the accessory pathway, we have first to look for, there are several algorithms described for this. That's the Aruda and the modified Aruda and so many, and even recently the St. George, which is described in the Lost Guidelines in 2019. But simply we can get a very simple algorithm. Okay, step one, we can look for V1. Okay, if we have a positive or a negative delta wave. If we have a positive delta wave, this means that this is a left accessory pathway. But if we have a negative delta wave in V1, this is a right-sided accessory pathway. And then next step, we can look for the inferior leads, if they are positive or negative. Okay, I will say it in a very simple way. Okay, just to get how to think about the accessory pathway and how to localize it for the juniors. And then we look for the inferior leads if it is positive or negative. If it is mostly positive, at least 2 leads from the 3 inferior leads, this means that it is an anterior accessory pathway. If it is negative in the inferior leads, at least in 2 leads from the 3 leads, this means that it is a posterior accessory pathway. And then the third step, we will look for the transition of the delta wave between the V1 and V2. If it is an early transition from negative to positive, this means that this is a septal accessory pathway. If it is a late transition, this means that it is a lateral accessory pathway. It's not close to the septum, it's not close to the AV node. And so we know from V1 if it is right or left. We can know from the inferior leads if it is positive or negative, if it is anterior or posterior. And we can know if it is septal from the precordial leads. But this is oversimplification for the localization of the accessory pathway.
Yes, but we have nowadays AV mobile applications.
Yes.
To apply the Aruda and the modified Aruda, but simply
I mean they have to think, how is the wave moving in the heart? If there's conduction across the posterior wall or the inferior AV annulus, and so that the impulse in the inferior leads will be getting away from the inferior leads, and so it will give negative delta wave. I mean, they know, just juniors need to know how the impulse moves in the heart during sinus rhythm and during tachycardia.
So simply in such ECG, we could simply say that it is left-sided and anterior accessory pathway, as it is positive in V1 and positive in the 3 inferior leads.
And negative in AVN.
Yes.
So
and in this ECG?
The opposite way around. We have a negative delta wave in V1. Okay. And so it is a right-sided accessory pathway. I'm sorry. And then it's negative in 2 leads out of the 3 leads of the inferior leads. It's a posterior one with an early transition. Mostly it's a right postseptal accessory pathway.
Yes. So what are the common tachycardias could be produced by accessory pathway to trans?
Before getting into the common arrhythmias or the arrhythmias that is involved in the accessory pathway, we have to know that this accessory pathway mostly, or it could conduct during sinus rhythm from the atria to the ventricle. And this is known as a manifest accessory pathway, which we will see in the ECG, okay? And it could work in the retrograde fashion from the ventricle to the atria, and not in the antegrade one. And so this is concealed accessory pathway. Okay, I'm talking about most forms of accessory pathway. Okay,
Yes.
it could work in both sides, antegrade and retrograde, but it could work in antegrade only, manifest, or retrograde only. This is concealed. It could be subtle, it could be latent, it could be intermittent. Okay, accordingly, we will describe what forms of arrhythmias might happen in patients with accessory pathway. Tachycardia might come from the impulse will come from the AV node, travel down the AV node, the normal pathway, and then get retrograde across the accessory pathway. As Dr. Osama described the two lengths of the re-entry circuit in the AV RT. Similarly, this what happens in the presence of an accessory pathway that conducts in a retrograde fashion. The impulse will get down the AV node. That's why it's called orthodromic because it's going in the normal pathway of conduction across the AV node, getting back across the accessory pathway. This would be getting down across the AV node. We get a narrow complex tachycardia. Okay, but if the opposite happens, getting down across the accessory pathway and going back across the AV node, since it goes from the atria to the ventricle across the accessory pathway, it will result in a wide complex tachycardia. Okay, and it's also a re-entry. And since it is going in the opposite direction in the AV node, it's called antidromic tachycardia. Okay, both of which are known as AVRT. The most deleterious and most that affects the patients we have juniors should recognize is the pre-excited one, when the atria conducts to the ventricle across the accessory pathway, and the atria is going into atrial fibrillation, what is known as pre-excited atrial fibrillation. It might lead it leads to a wide complex tachycardia that is very fast, that might reach 300 beats per minute. Okay, this is a very important form of tachycardia that has to be recognized by the juniors in the ER.
Dr. Osama, if we want to sort accessory pathways from common to less common in Yemen, which is more frequent encountered in Yemen during ablation?
Well, the most common are the left-sided
Left sides.
accessory pathways, yes.
And the most
right-sided usually posterior-septal, but the most common are left-sided.
Yes, but the most dangerous is the right
Of
anteroscope.
course, parahysema.
Parahysema accessory pathway. Okay.
I think this is the normal literature, Dr. Osama.
Yes.
Yes. So what is your comment, Dr. Azza, on such ECG, and how could we diagnose accessory pathway or suspect it is accessory pathway induced arrhythmia?
It's a narrow complex tachycardia. It's around the complex is around 80 milliseconds. It's less than 120, as Dr. Osama described in the beginning of the lecture. It's a regular one, and then we are looking for the P waves. We can suspect a P wave at the end of the complex here. Okay, mostly very consistent. We can see it in the strip down here. It's very consistent, and so we can say that this is a short RP tachycardia, but not very short, as shown in the algorithm shown by Dr. Osama. It's short, but not very short. Okay, it's not less than 70 milliseconds, and accordingly, I will be suspecting EVRT.
And this ECG?
In this ECG, we can see wide complex tachycardia, which will revert to Dr. Amna in her recognition of the differentiation of the wide complex tachycardia. It's very rapid. It reaches 300 beats per minute. Very rapid. And this very rapid wide complex tachycardia, we have to suspect the presence of an accessory pathway, especially if it is seen in children and adolescents. Showing a right bundle branch block morphology in V1. Mostly, I think we can recognize a P wave following every complex, and so there is no EV dissociation. And as Dr. Amna had said, the differentiation of wide complex tachycardia is number one VT, SVT with aberration, and antidromic tachycardia utilizing an accessory pathway. This very rapid rate should drive the suspicions of antidromic tachycardia.
So in antidromic EVRT, Dr. Azza, could we use the QRS, the whole QRS as positive or negative, like delta for localization for the accessory pathway?
Yes, because mostly the tachycardia is going down the accessory pathway and back across the EV node. And since it's going down the accessory pathway, we can localize the accessory pathway from the ECG, because this is what, this is the pathway, the accessory pathway.
So it is left side accessory pathway.
Yes, and this is true. Yes.
Full pre-excitation.
Excuse me?
Full pre-excitation.
Yes, full pre-excitation. Yes, this
full
is
pre-excitation. Yes, and this is very
this is
frequent.
the third form of tachycardia that the patient might experience if he has a manifest accessory pathway with antegrade conduction. This is wide irregular tachycardia that reaches the shortest or interval is even more than 300 milliseconds, as we can see here. And so we have to suspect this couldn't ever be AF with aberration. I hate I hate this answer.
Very rapid to
yes,
be with
very rapid. Shortest or interval is less than 250 milliseconds, and so we have to raise the suspicion this is pre-excited atrial fibrillation.
DC shock, but not to forget heparin for such patient. And
very common.
By the way,
cases, we don't. In those cases, we should not use amiodarone in any case.
Yes, this is contraindicated in the
patient will die.
Yes.
Yes, there is
because the amiodarone will stop the conduction in the AV node, and all the AF waves will pass by through the accessory pathway, and we will have
there is a reported risk of VF by using amiodarone in patient with pre-excited AF. Yes.
But we don't have the procainamide in Egypt a very long time ago.
Just DC shock. But I think it is safe to use amiodarone after termination of the attack. يعني to prevent the recurrence of AF, we could use amiodarone, but not to use for acute cardioversion.
We noticed in Yemen that this arrhythmia happened after energy drinks. Do you have it in Egypt? Power horse and something like that.
And alcoholic drinks may accelerate.
Alcoholic is not diffused in Yemen. It's not diffused in Yemen, but power horse and energy drinks are diffused. And we found many patients after that. They got pre-excited AF.
I noticed the patient with sinus tachycardia with frequent energy takers, but pre-excited AF, I think accessory pathway, it is a congenital one. Maybe it is the energy drink increase the risk of atrial fibrillation, but the accessory pathway is already present.
Yes.
In this ECG, we could appreciate presence of long RP tachycardia. So how could we think in such ECG?
Yes, it's a narrow complex tachycardia. It's regular, and when you think about the P wave, it's a long RP tachycardia. If I'm thinking about a long RP tachycardia, it's either atrial tachycardia. It's also inverted in the inferior leads. Okay, you can appreciate the P wave inverted in the inferior leads, which means it's coming from the floor, or it's activating the atria in a podocranial fashion. Along RP tachycardia, the most common is the atrial tachycardia, or atypical EVNRT, fast slow re-entry, or a slowly conducting accessory pathway, which is known as the permanent junction reciprocating tachycardia. And this is considered to be a typical form of the accessory pathway because it is slowly conducting.
GRT.
Yes, and it results in it's an incessant tachycardia, just like the atrial tach, and it might lead to tachycardic cardiomyopathy. You see it mainly in children.
Could the electrical interference in such ECG could refer to any of the differential diagnosis?
I think mostly, Dr. Muhammad, that this is due to the rapid tachycardia. It was in the past considered a clue for accessory pathway, but after that, it's not. Any very rapid rate of tachycardia might lead to electrical interference after exclusion of pericardial effusion.
Yes.
I think a trick in this ECG, if there is a fixed RP interval, it will be AVRT.
Oh,
if
yes.
It is fixed.
Yes, this is true because atrial tach does not depend on the AV node.
Yeah.
Yes. This is a typical form of pre-excitation.
Yes, a very difficult ECG.
To the juniors.
I think the alternance of RR interval are alternance either for atrial flutter 1-to-1 or AVRT also.
Yeah.
Yes. This patient has narrow complex. Then the patient get left bundle-like morphology during tachycardia. Mahim fibers, Dr. Azza?
Mahim fibers is one of the atypical forms of pre-excitation. It's a decremental accessory pathway that conducts only anti-gradient. The reason that the people should, juniors should know this, because it presents with the left bundle branch block morphology in the ECG.
Yes.
It's a wide complex tachycardia.
Yes.
And so it's one of the differential diagnoses of wide complex tachycardia with the left bundle branch block morphology. It's very subtle pre-excitation during sinus rhythm, as we can see on the left ECG. We can although it conducts only anti-gradient. It doesn't work in the retrograde conduction, and so it only comes with an antidromic tachycardia.
With late transition.
Excuse me.
It has late transition zone usually.
Yes, you mean during the tachycardia? Yes, this is true.
Yes,
It has late transition, and it has a superior axis mostly, or a left superior axis. Yes.
Left superior, left bundle. Okay.
It mostly its site is at the lateral annulus of the tricuspid, very rarely to be septum, and very rarely to be leftish.
Dr. Azza, there is a current concept in the guidelines about asymptomatic pre-excitation. Is it safe to leave the patient without any further management, or what is the current guidelines-based algorithm to deal with asymptomatic pre-excitation?
Some patients do not present with tachycardia. They only have the ECG with pre-excitation that was discovered accidentally during applying for a job, or applying for to play or to play tennis or doing any
sport activity.
Yes. And so the guidelines give us some clues how to approach these patients. Patients having high risk for in their occupation, working as driver or pilots, or high risk occupations, or sharing in competitive sports, they should, if they were discovered accidentally for accessory pathways, they should have an EP study for risk stratification of this accessory pathway, if it is conducting past accessory pathway, or if it is just a standby accessory pathway. This for patients with high risk occupations. Otherwise, the EP study is class 2A for risk stratification for patients with asymptomatic accessory pathways discovered accidentally. Okay.
So we could say that EPS is recommended for any patient with asymptomatic pre-excitation for risk stratification.
Yes.
We say that intermittent pre-excitation is safe and we shouldn't proceed for EPS?
Actually, I don't agree with this because sometimes intermittent pre-excitation, it depends when it's working, or when it's seen working in the antigrade fashion from the atrium to the ventricle. It might conduct at a very fast rate, and so intermittent pre-excitation is not considered a low risk feature for accessory pathway.
Yes, we should go for EPS for risk stratification.
Yes.
Guidelines.
We shouldn't depend on non-invasive maneuvers like exercise ECG or host.
Yes.
Actually, I had a case 10 years ago with intermittent pre-excitation, and then I told him it's not serious, and so 5 years later he got pre-excited EF and collapsed. So it is not a clue for safety of
yes,
or for if it is benign or not. Yes,
it could be deceiving.
Yeah.
Yes, and this is class 1 recommendation for catheter ablation in accessory pathways with very short effective refractory period. So moving to irregular tachycardias, I tried to summarize irregular tachyarrhythmia in such algorithm, starting with Cherchez-Lavie in French. If the atrial activity is undetermined, or atrial activity has a rate more than 40, so we have to move for the second step. It is irregularity. It could be atrial fibrillation, whether it is narrow complex or wide complex. And wide complex could be bundle branch block and could be accessory pathway. But if the undetermined atrial activity has some sort of regular irregularity or occasional irregularity, especially if it is wide complex. If regular irregularity, wide complex tachycardia, we could think of bidirectional ventricular tachycardia. If it is occasional irregularity, it could be clue for diagnosis. And this is my question to you, Dr. Osama. If we have narrow complex tachycardia, and we have occasional BVC that occurred in the narrow complex tachycardia, could presence of BVC and extrasystole or BEC or ectopic beat in the narrow complex tachycardia, could we refer to any one of the differential diagnoses?
Actually, it can be a functional too. Long RR followed by short RR interval could be an Ashman phenomenon.
Yes.
Otherwise, we can decide that this is ventricular extrasystole. Like very common to be an Ashman phenomenon. It is it goes through refractory bundle and aberrant coarse complex.
But yes, you are right, Ashman phenomena. But presence of ectopic beats and that couldn't terminate the tachycardia. For my approach, I could say that this tachycardia is not EVNRT, but it could be EVRT or it could be atrial tachycardia. But presence of ectopic beat inside the arrhythmia, in most of cases could rule out EVRT. So moving to the rest of algorithm, if the atrial activity from 100 to 250, we could think of atrial tachycardia with variable block if it is monomorphic atrial activity, but in multifocal atrial activity and we have atrial rate more than 100, we could think of multifocal atrial tachycardia. If the atrial activity rate from 250 to 400, so it is atrial flutter with variable EV block. We know that multifocal atrial tachycardia is frequently encountered in patients with COPD and usually respond to calcium channel blockers. And this could direct us to an important question that the tachycardia could be automatic or could be re-entry, as we said in the first of presentation. Automatic tachycardia, especially automatic atrial tachycardia. My question to all of you, Dr. Azza, Dr. Amna, Dr. Osama, is it calcium channel dependent or sodium channel dependent? As we know that slow calcium channel is responsible for the automaticity property of the heart cells. So automatic atrial tachycardia per se or multifocal atrial tachycardia, the automatic activity utilize calcium channel or sodium channel?
I think it's sodium channel. If it is atrial, junctional will be a calcium, more or less.
It is a debatable point, but we know that funny sodium channel present in SE node for automatic property, and there is current research that says that funny sodium channel is also present in
they are present everywhere.
Yes, everywhere. But I tried many times for atrial ectopics and atrial tachycardia and multifocal atrial tachycardia calcium channel blocker, it always worked. So it could be utilized calcium channels for automatic property. What is your opinion, Dr. Azza?
Actually, I do agree with Dr. Osama. I thought I think it's a sodium channel dependent.
Sodium channel dependent arrhythmia. So the best in absence of structural heart disease to use sodium channel blockers.
I tried the blocker alone in some cases and it works.
It works. Evocative, yes. And there is nowadays trials utilizing ivabradine for controlling of permanent atrial fibrillation. It is less effective than digoxin, but it is to be tested in the future research. This is ECG. We could appreciate presence of multifocal atrial tachycardia with presence of irregularity. This is the typical multifocal atrial tachycardia, which is frequently encountered in patients with COPD. And this is the atrial fibrillation, undetermined atrial activity, irregularity, but it is the benign form of wide atrial fibrillation. Atrial fibrillation بنسميها بنت حلال بالعربي يعني. It is not pre-excited atrial fibrillation, whether it is aberrancy or underlying left bundle branch block, and this is repetition of the accessory pathway based arrhythmia دي بقى اللي مش بنت حلال يعني, which is pre-excited atrial fibrillation, and we could utilize the whole QRS as a delta wave, full big delta wave, and we could appreciate that it is maybe left side, left posterior, Dr. Azza?
Yes.
Left posterior accessory
pathway. It is positive in V1, which means it's a left-sided accessory pathway. and negative in the inferior lead. It's a left posterior accessory pathway. Yeah.
Yes. The key trick here, not to miss anticoagulation before DC shock of the patient, and to avoid amiodarone at all. It is reported in literature increase the risk of ventricular fibrillation. And this is.
Would you recommend isolate the veins? Would you recommend isolate the veins, Dr. Muhammad, Dr. Azza, Dr.
Recommend for this patient?
DC shock.
Would you recommend? Yeah, would you recommend? I know. But would you recommend isolate the vein as well as the ablation of the
immediately?
Of
it should be ablated immediately. I think if possible, not to leave the hospital before ablation.
No, I'm speaking about pulmonary veins.
We don't recommend vein isolation. We have to ablate the accessory pathway, and the fibrillation will disappear.
Sometimes after only ablation of the accessory pathway, AF will not come again. So I think it is not one procedure ablation for both accessory pathway and pulmonary vein isolation. We could start only with accessory pathway and look for the atrial fibrillation. Will it come again or not? What do you think, Dr. Anna, Dr. Azza?
I totally agree with this.
Yes. But I got patients.
The activation of the atria retrogradely, this is which make AF starts.
Focus.
So the accessory pathway could be the trigger behind the atrial fibrillation. So
because they are very young people, they don't. I don't think there's a substrate in the atria of AF.
Yes, and by the way, pre-excited AF always recent onset atrial fibrillation. He will not stay for 48 hours or for long days, so their left atrium will be always smart. And this is application of regular irregularity in patient with wide complex tachycardia, which is bidirectional ventricular tachycardia. So come to the conclusion of our session. We talk about regular narrow complex tachycardia, regular wide complex tachycardia, accessory pathway based tachyarrhythmia, and irregular tachyarrhythmia. If we want to summarize key message to our juniors to handle in the emergency room, not to miss a critical patient. Dr. Azza, what is the most important point you want to deliver to our candidates today?
Number one, revise the clinical data of the patient. This is very important. Yes. Number two, look closely to the ECG and wisely. Don't rush for a diagnosis. Just go in steps: regular, narrow complex, wide complex, and then regular, irregular. If you can find the P wave or not. If he goes into if juniors will go for a systematic approach, they will not miss any patient. And always remember the pre-excited atrial fibrillation, cardiovertebration. Don't give them any medications, any other medication.
Dr. Anna.
For juniors, I think they have to make a good exam for the patient. If there are hemodynamic instability, they have to go to the cardioversion. Otherwise, to record a good ECG and not to forget to make vagal maneuvers, the other leads like Leon or Lewis leads, to appreciate the P waves. Then for patients who have accessory pathways, they have to contraindicate all sports activity until the patient had a good an EPS to stratify his risk. Accessory pathways may be the cause of dilated cardiomyopathies because they induce an
tachycardia induced the cardiomyopathy.
No, not tachycardia induced, but the
desynchronization. You mean
desynchronization of the
yes.
Of the ventricular of the left ventricular, and the ablation of the pathway may correct this issue.
Yes. Dr. Usama.
Always stability of the patient is our guide for the treatment. We repeat this words everywhere. And for wide complex tachycardia, never use verapamil unless you are sure that this is vesicular tachycardia. Otherwise, you will transform a benign arrhythmia to a malignant arrhythmia, and the patient may collapse. Regular arrhythmia cannot be a Wolff Parkinson White unless a pre-excited AF. And hoping to consult always the seniors if you have a doubt.
Thank you. And my advice is for our colleagues to be patient in interpretation of ECG after termination of the acute event. And if you are a patient, you will come to the end of our presentation, and we hope that the interactive discussion is helpful to all of you. I'd like to thank Professor Azza Kata from National Heart Institute and Dr. Amna Allouche from Tunis, Dr. Osama Nuno from Yemen. It's my pleasure to be the moderator of the day, and thank you all, and good night.
Thank you very much.
Good night.
Very much.